pregnancy पे. Towards the end of the talk, towards the end of the discussion, we have a couple of slides on pregnancy.
Yeah.
Like everybody preconception they have to check. And then
Okay, ठीक है. हाँ, जो भी है फिर वो बोल देना.
pregnant women has to check. It's not like a 20 to 24 weeks.
Nothing great in terms of
no major change. Okay. So
but
then
anyway, we'll mention that. We'll mention whatever is.
And then we go to Rakesh, and then again to Rakesh. And ऐसे बस करते रहेंगे alternate. एक बस जगह है जहाँ पे मैंने खुली स्लाइड्स कर दी थी. वो ये मैनेजमेंट ऑफ GDM, बिकॉज ये सिंगल स्लाइड में बहुत क्राउडेड आ रहा था. So whoever gets this, we have tables. And these are the tables. First of all, we talk about, and we don't have to do it in all detail. Na? Just be aware of all these things.
This is pediatric type 2 DM.
Yeah, and be aware of this.
So, I mean,
अच्छा heading गलत हो गई है.
Okay, excuse me everyone. It's 6:30. So may I give the countdown?
नहीं, give 30
Just a second.
seconds. 30 seconds.
That is a table regarding the
pediatric.
Yeah.
So now we are done, I think. ठीक है. You can give the. Yes. अभी कर देता हूँ.
Yeah. So I think that Apurva ma'am will start. So may I give the countdown, ma'am?
Yes, sure.
Okay. 5, 4, 3, 2, 1. We are live now, ma'am. You can start.
Hello, everyone. A very good evening and a warm welcome to all. Welcome to all the 3 experts who have spared their valuable time and joined us today. Also, welcome to all the delegate doctors who are joining in from various platforms. As is common knowledge, the recently released ADA 2022 is an extensive living document of 270 pages divided into 17 sections covering all the aspects of the complex and chronic illness of diabetes and provides ADA's current practice recommendations. Today's program, which is organized by the Lupin Metabolics team, is on Decoding ADA Standards of Care in Diabetes 2022 with experts aiming to simplify the updated recommendations made by ADA and highlight its relevance to the Indian scenario. I welcome all our 3 expert speakers for today. We have Dr. SANJAY KALRA sir, Dr. RAKESH SAHAY sir, and Dr. Arundhati Dasgupta ma'am with us today. Dr. KALRA sir is a consultant at the Bharti Hospital, Karnal, and is a visiting professor at AIIMS Rishikesh. Sir has held many important positions in the past and also presently. Sir is a past president of the ESI, the president-elect of the South Asian Federation of Endocrine Societies, deputy chair advocacy and partnership working group at the ISE. Sir is the member of the Program Organizing Committee, International Congress of Endocrinology at Singapore 2022. Sir has also had numerous important publications in national and international journals and numerous textbook chapters. Then we have Dr. RAKESH SAHAY sir. Sir is a professor and head Department of Endocrinology at the Usmania Medical College and Hospital, a consultant endocrinologist at the Sahay's Endocrine and Diabetes Center, Amirpet at Hyderabad. Sir is the president of the ESI, vice president of the South Asian Federation of Endocrine Societies, section editor of Tropical Endocrinology, Endotext, which is an online textbook of endocrinology. Sir has won many awards and accolades, including the National Academy of Medical Sciences 2021. Sir has over 150 publications to his name in many international and national journals and has authored various textbook chapters and monograms on diabetes and endocrinology. Thirdly, we also have Dr. Arundhati Dasgupta ma'am. Ma'am is a director and consultant endocrinologist at Rudraksh Superspeciality Care at Siliguri, West Bengal. She also has numerous awards to her name, like the A.V. Gandhi Award of 2012 of the Best Thesis, the Diabetes Awareness Initiative Award of 2018. Ma'am has done numerous awareness programs on endocrine disorders across West Bengal, Sikkim, Bihar, and Nepal. She is a course coordinator for PHFI and several other national and regional training programs. She has presented at multiple national and international platforms and has several publications to her name. She also has contributed various chapters in numerous books. Welcome, sir, and welcome, ma'am. With that introduction, I would hand over the platform to Dr. KALRA, sir, to start today's session. Over to you, sir.
Thank you, Dr. Apurva, and warm welcome to everybody who's logged in this Sunday evening. The only thing that is constant is change. And that is very true of diabetes, very true of everything in our subject. But if diabetes is a dynamic disease, if it is an ever-changing disease, ever-evolving understanding, then the only way we can defeat it is by being faster than that, by being even more dynamic. And this is what we do through the ADA, the American Diabetes Association Standards of Care, which are an annual guideline. And the best part is that they're released at the beginning of the year. So now in December 2021, we have the Standards of Care for 2022. In the next 1 hour or so, we'll take you through the latest, through the changes, through the novelties of the 2022 Standards of Care. And like Dr. Apurva has already introduced, I welcome Professor Rakesh Sahay and Dr. Arundhati Dasgupta to this discussion. Dr. Sahay, Dr. Dasgupta, we'll benefit a lot from your insights, from your knowledge. So thank you for being with us.
Thank you, sir.
We'll come to the first section, and this is about improving care, promoting health. Now, Dr. Rakesh, what changes have taken place in the 2022 Standards of Care?
Yeah, thank you, Dr. Sanjay. At the outset, let me thank you and Lupin for organizing this program. And as you said, change is is the most constant thing in life which happens, and diabetes is an ever-changing subject, as you're seeing, and the ADA 2022 probably exemplifies that there are many changes, many small changes. I mean, even though you may not say that the entire aspect has not changed, but there are many important changes that have happened in this document, and I think that is what we're going to discuss today. And the most important thing to start off with is actually the fact that diabetes care has to be very patient centered, has to be involving the patient to a great extent, or the person with diabetes. We don't even call the person, a patient as diabetic patient, but we call him as a person with diabetes. And so we need to sort of increase the health literacy and numeracy of a person with diabetes. So that's the important thing that has been highlighted in this new document which has come out. And they have emphasized the role for the need for effective communication, deciding a treatment plan along with the patient, and because patient engagement is very important in a complex disease like diabetes, because if you want to have a long-term glycemic management to be maintained and to protect the individual from the complications of diabetes, the involvement of the person is very important, and that has been highlighted here. And what has also been said is that instead of having a reactive approach, what they have suggested is that we need to be more proactive in terms of educating the person, and also in terms of highlighting the need for calling the person at appropriate times, informing him about the need for undergoing tests at periodically. So those things have been highlighted in this guideline. And also the important point that has been highlighted is that to keep in mind the background of the person, the health literacy of the person, the economy involved, I mean the economics of the medication costs and all that. So all those things have been highlighted, and to take care of this, it's beyond a single doctor who can do this. A team approach is required, and what we require is community health workers who would provide cost-effective alternatives for providing diabetes self-management, education, and support. And so this is something which has come out very clearly in this guideline. At the outset of the guideline itself, this point has been highlighted. And in fact, we have also been working on this through the PHFI and the Center for Disease Control in we had a trial. We did a translational trial called the CARS trial way back about 8 to 10 years back. We started that, and we had clearly shown the importance of having a care coordinator who is just maybe a 10th pass or a 12th pass person who is able to communicate and effectively form a bridge between the physician and the person with diabetes, so as to improve the adherence and increase the utilization of the healthcare services.
Thank you, Dr. Rakesh. Dr. Arundhati, this document comes from USA, which is arguably the richest nation in the world. And they are talking about community health workers, like our ASHA workers. They're speaking about literacy and numeracy. I thought literacy and numeracy are things that are of concern only for, some of the least developed countries in sub-Saharan Africa. And they also talk about cost of medication. I thought I'm the only person in the world who bothers about cost, me and my patients. So what is the relevance of this document in our scenario?
Thank you, sir. For the question. I think it's good to see that ADA guidelines have spoken up about cost, about health literacy, and about community health workers, because ADA guidelines are, though they are basically formulated in the US, they're followed across the world. And I think probably that realization, I mean, they would have a certain sector, of course, who are also in whom they also have to think about all these aspects. But for us, I think it is all the more important. Definitely, sir, as you were saying, we are aware of a lot of medications which could have this benefit or that. But whenever we're prescribing, the first thing that comes to our mind is definitely cost, because we just cannot prescribe something which the patient will not be able to bear. And cost is a big issue because we do not have insurances. Most of the people are paying from their pockets. So that is the first thing I think that comes to our mind when we are writing something, apart from the individualization. When we are talking about an individual, these points that have been put forward, the health literacy of the patient is so very important, because when you're explaining something, as it said, you should communicate to your patient. So when you're explaining something to maybe a CEO of a corporate sector or a person who's in the IT industry, and you're explaining something to a person maybe from a rural background, a farmer, and we see both ends of the spectrum, and we see people who know a lot, who know a lot from Google, and we see others who absolutely believe in us blindly. They don't know anything about diabetes. They know there's something called blood sugar, and I'm going to the doctor for blood sugar. Whatever we try to explain to them beyond that is really Latin and Greek to them. So these points, the importance of this is, I think, all the more marked in nations like ours, where we definitely have to put forward what we are thinking, what we are planning. Now, if I tell most of my patients that I'm giving this for your cardiac benefit, they would just take it point blank. I mean, then I would have to go forward and explain, okay, so this is the cost. Would you be able to bear it? This is not a benefit that I'm going to be able to show you immediately, unlike the blood sugar levels, which are going to come down. So this is something which I hope to see in long term. So we really have to discuss this. As also, I think that probably one drawback in our practice is that we do not discuss a lot with our patients, unlike a lot in the West, probably because the burden might be lower there. Our patient burden is much higher, so we do not get time enough maybe to discuss with our patients. So probably these guidelines will help us strategize our clinical practice better, because every time these guidelines come out, we read them, we know these things, but they are reinforced in us, and we tend to think about them again, and gradually, as we start practicing them, we get into the practice of doing it. So getting into the practice of talking to patients, taking them into the loop, making them understand, individualization, cost consideration, and community involvement, health worker involvement is indeed a very strong statement that has come out, and is a very important statement for us, particularly for us, all the more for us, because as we know, our sectors are very divided, and How many endocrinologists or diabetologists are able to see these diabetic patients? Most of these, they'll probably ask the ASHA worker, the Anganwadi worker, that, I'm taking this, should I shift it? Or I was supposed to go to the doctor. I've been to the diabetes doctor 2 years back. I was planning to go again. So these are people who can have strong influences and tell them small things, that you need to go to the doctor, get your eyes checked every year, get your kidney checked every, small things, but which would have a very, very strong statement in terms of what's happening in the total impact of the things in the whole of the country.
So really strong relevance for us in India. And the best part is that if you ever felt guilty that as a doctor you did not prescribe SGLT2 inhibitors or GLP-1 RA to everybody because of cost consideration, don't feel upset. However, do discuss with your patient. Do spare a few minutes to talk to your patients about immediate benefits, about long-term benefits, and then let the patient take a decision. Also remember that yourself as an individual, sometimes you change your decisions. Not sometimes, all the times we keep on changing our mood, our decisions. So your patient also has a right to change. Today he or she may say, I don't want insulin. You can ask again next week. By next week, the patient may have changed her mind. So, but all that will be based upon diabetes literacy, diabetes numeracy. I learned another word, another English word, which is called oracy, ORACY. Oracy means the ability to the ability to express your emotions or feelings in words. Now, some people have a way with words. They're able to explain what they are feeling. So somebody might come and tell you, sir, I'm not feeling comfortable because of such and such a thing. These are my symptoms. Another patient may say, Doctor, something is wrong with me, but I really don't know what is wrong with me. And then you say, but until you tell me, until you are oratic, how will I get to know? And then the answer is, madam, you are earning 500 rupees consultation. It is your job to understand what's wrong with me. If I were to know the diagnosis, I would pay myself. So point well taken. But let's talk about diagnosis of diabetes, Dr. Arundhati. We keep on talking about the diagnosis and classification. Have any changes taken place in the ADA guidance this year?
So there have been certain changes which have been made in terms that probably some things have been brought forward more strongly. One thing that has been put forward is that, we ask our patients to go for OGTT, the oral glucose tolerance test. So what ADA has said this time is that when you're using a OGTT as a screen for diabetes, the patient should have had adequate amount of carbohydrate intake, which has been mentioned as like 150 grams per day for at least 3 days prior to testing. So I think in our population, this should not be a problem because we are basically a carbohydrate eating population. And most of our patients generally do have much more than 150 grams per day. But we need to be sure of this so that we get an adequate results when we are testing. One more thing that has come up is this the importance that has been given to the monogenic diabetic syndrome. So you said, like, no matter what is the current age of the patient that you're treating, if this patient was diagnosed with diabetes in the first 6 months of life, then this patient should be recommended for a genetic testing for neonatal diabetes. And they've said that, okay, if you have a patient who doesn't really fit into the type 1 or the type 2 and has a very strong family history of an autosomal dominant pattern of inheritance, and do get the patient tested for Modi, So this is something that that has been mentioned. We knew this, that if you see this kind of family history, if it's not fitting, you should be doing it. But more often than not, we do not do it, probably because most of us do not have access to the genetic testing. But now I think it is available. We can send it forward. It's available in one or two centers, a few centers in our country, and they're open to receiving samples. So I think we should go ahead so that we have more and more data about Modi. There was recently a paper, I think, which we had seen in ESICON this year, where they said that these type 2 diabetic patients, which have been branded as type 2 diabetic patients from our own country, from various parts of the country, so many of them have turned out to be Modi once the genetic testing was done. So this is an important area. And one more significant change, and I think a welcome change, is that screening for diabetes should begin at 35 years. All this while it was at 45 years, we were doing it at 40 also. But now, since we're seeing this trend of early onset diabetes, and we've been seeing it for a long time, and I think a lot of us, including myself, we've thought that Probably we've always had this feeling that 45 is too late, even 40 is too late. So 35 is a welcome change. I think we should start screening for pre-diabetes and diabetes. I mean, even if somebody doesn't have any other risk factors, maybe you should start screening at 35 years. So that has been put forward strongly by ADA.
So again, a more proactive approach coming from the ADA. First of all, regarding ensuring that the right label is given to a person with diabetes. The label should be correct because it actually influences treatment, it influences counseling, it also influences outcomes. And the second is that we should begin testing earlier. So, Dr. Rakesh, what is the relevance in the Indian scenario? And basically, in India, so far the guidelines were that you have to do a venous fasting glucose and a venous GTT. But it's very difficult to get these venous samples done, so cumbersome, and everybody is in search of a quick fix solution. Any recommendations from the ADA or from the World Health Organization regarding this?
Yeah, so I think one of the changes has been the acceptance of the glucometer readings also for diagnosis of diabetes. They said they would, the recommendation is to use the same 126 as the cutoff for the fasting, fine for the postprandial, because you see there is a difference between the venous glucose and the capillary glucose in the particularly in the postprandial phase. A value of 220 is taken as a cutoff for diagnosing diabetes using a glucometer. So that has also been a welcome change. And the other important aspect, as Dr. Arundhati has highlighted, is the relevance for India is the lowering of the age for screening for diabetes. That is from 45, it has been lowered to 35. This is particularly relevant in our country because we always see that we tend to have diabetes occurring at a younger age, at least a decade earlier than the Western population. And so for us, we were earlier also, we were always speaking about screening from 35 years of age. And so ADA has also now recommended initiating screening from 35 years of age. And they also mention, if you look at the document carefully, it also mentions that those who have risk factors, that is those who are obese, or those who have a strong family history of diabetes, or those who have hypertension, or those who have got cardiovascular disease, you may screen them earlier also. So there is no need to restrict to start screening them at 35. You can screen them at a younger age also. And this 35 is for people who don't have any of the risk factors. Even without risk factors, you may have to screen them at the age of 35.
Another risk factor that I've begun seeing now in my clinic, and it didn't exist a few years ago, that is the young boys and girls who go to gyms and who indulge in anabolic steroid abuse.
Yeah.
So when they come back and you talk to them about the fact that they have high cholesterol or they have high liver enzymes, they don't bother too much. And the family also doesn't bother because it doesn't hit them. But the moment you show them even a slightly raised blood glucose, then they get upset. And of course, you can talk about testosterone and spermatogenesis, but that is not something you would feel comfortable sharing with the sister or the mother. But glucose is a number which allows you to engage the entire family in positive motivation of the boy to come out of this cycle of misuse of steroids. Dr. Rakesh, continuing with this discussion, you've talked about the fact that it is important to screen and diagnose pre-diabetes and diabetes early. The main reason for doing that is so that we can institute correctional interventions so that we can prevent and delay complications. Are there any other recommendations from the WHO, from the ADA?
Yeah, I think there are some recommendations which have been updated in this edition of 2022, which clearly says that we need to monitor for the development of diabetes and pre-diabetes. We need to monitor those with pre-diabetes. We need to screen them every year. Look for the change in the blood glucose levels, and the reason why this has to be done is because we have clear evidence of the benefit of lifestyle changes in the form of bringing about a weight loss of 7% and increasing physical activity, encouraging physical activity to the tune of at least about 150 minutes per week. This has been shown in the DBP to have excellent results, reducing the progression from pre-diabetes to diabetes by more than 58%. So clearly this intervention has helped, and there is a very good evidence for this intervention, and that's the reason why this has been highlighted again. And the other important thing is that many people are not able to do this on a regular basis. They are not able to bring about a change in their physical activity. They are not able to, or it may also be because of various other factors that may be interfering with their physical activity. So in such situations, it has been highlighted the importance of metformin has also been emphasized, and particularly in the younger individuals, those with a BMI more than 35 kg per meter square, those with a higher fasting plasma glucose level, that is a plasma glucose more than 110 milligram per DL, which qualifies for the diagnosis of pre-diabetes, and those with a HbA1c which is more than 6%, and particularly in the women who had previous history of gestational diabetes, because they have a very fast progression to diabetes. So these are the groups of individuals with pre-diabetes in whom metformin can be considered for treatment, for preventing the progression from pre-diabetes to diabetes, while lifestyle changes have to be advocated for all the people with pre-diabetes. And the another point that has been highlighted also is that once you start using metformin, they have highlighted the need for periodic assessment of vitamin B12 levels in those treated with metformin, so as to prevent, so as to detect any B12 deficiency and correct it appropriately.
Dr. Arundhati, would you like to continue with this? Monitoring annually, 150 minutes of exercise, moderate exercise per week, 7% weight loss, metformin for pre-diabetes, vitamin B12. So many important take-home messages. How relevant are these for India? Are we already doing them? Should we pull up our socks? Should we not bother about them at all?
Well, I think whether we've been doing them or not has been very individualized. It has not been a part of the guidelines. So a lot of people have not been probably doing it, because you see so many patients who come to you with florid diabetes now. And when you look back at their reports, you see that maybe about 3 years back, they did have a pre-diabetic range, which was not maybe told to them, or what was not followed up. They didn't give much importance to that. So this concept of checking for pre-diabetes annually, I think, will be a very strong message to the doctors and to the patients alike. So once you know that, I've got pre-diabetes, I've got to check something, and they'll start taking it seriously also. And we've known all along, DPP came years back, and we've known all along that, this is what we should be telling our patients: intensive life behavior. But I think if we take our patients into the loop at this point in time, so where the patient is a pre-diabetic and comes to you, and there are patients who will understand, you can tell them about this and this has happened in this study, and wherein so many people, 58% is not a small number. So 58% of the people, they actually achieved this diabetes remission part of it. And so that is a very positive message. And when it is a part of the guidelines, you'll remember it more often. I would say you would use it more often in your practice. And it is definitely of relevance to the Indian scenario. The vitamin B12 part, I think, sir, because a lot of our patients are also, apart from being treated with metformin, they're also vegetarians. So vegetarian people are more likely to become vitamin B12 deficient, as also elderlies and patients and others. So this periodic measurement, none of the data is new data, but the fact that it has been put forward in a part of a guideline would only make this more stronger, more relevant in practice. So I think a lot of us do miss doing the vitamin B12 levels all the time. I mean, maybe after a certain period of time of metformin use. So we should be remembering it more closely. I think we should be following this vitamin B12 levels more closely. And this metformin bit, I think it is a welcome change again, because there are so many times, there are so many patients in whom you feel the need to put in metformin, and at times we do put in metformin, or at times we do not. We're not too sure. I mean, okay, I might or might not is generally the concept. So now when we know that it's part of the guidelines, which says that, yes, these are the people very categorically, this age group, this BMI, this fasting, this HbA1c. So now you know precisely where to put in the metformin. And I think that would, change practice, or bring about a more proactive, as you said in the very beginning, a more proactive approach to these pre-diabetic patients, so that they do not go into diabetes, or they fare better across the years.
So very important messages, and these are all important for our country. Many times we see people with glucose in a pre-diabetic range, and we just tend to ignore it. I myself am guilty of that. I mean, it doesn't matter. It doesn't matter. And I think inside my heart, if I check, what I feel is if I ignore it, I tell the patient, don't worry about it, then the conversation stops there. I save a few minutes in the OPD. But if I tell the patient, it is important, we need to work upon it, then obviously the next question is going to come, sir, what should I do? What work should I do? And then that is a few minutes discussion. But from now on, I promise myself and I promise everybody who is listening that I will not do this. Even if there is a glucose of 101, I will make sure that I take that opportunity to talk to the patient about prevention of diabetes, about remission of diabetes.
Most of the time we generally tend to say, okay, say you may go about it with a little bit of exercise, don't eat. We'll not be very specific about what we are saying. We've not been. I think we are all guilty of that, as you said, sir. So now when we know that, we should go about it in a proactive way, probably all of us will change our practice a little bit.
And the other nice thing is I see metformin being brought to center stage for prevention of diabetes. We are willing to use vaccines to prevent disease. Vaccines cost much more. The potential risk of side effects is more. Not to say that I am myself not vaccinated, we are. But we are willing to undergo that risk for a particular benefit. And when it comes to taking a 1 rupee tablet, so simple with virtually no possible adverse effects, then we tend to drag our feet. So a simple mnemonic to remember, somebody with a swift onset of diabetes or pre-diabetes, that's age 25 plus, somebody who is stout, that is BMI on the wrong side, and for India, we might have to bring this down to 30 perhaps instead of 35. Somebody with severe hyperglycemia, somebody with sustained hyperglycemia, where the HbA1c is higher. A high HbA1c, 6.1, 6.2, 6.3, tells you that the pre-diabetic stage is sustained. And somebody from the softer sex, a lady who has had previous GDM. So swift, stout, severe, sustained, softer sex. All these, if they have pre-diabetes, then I think we should consider metformin. If we can continue with you, Dr. Arundhati, we are speaking of pre-diabetes, but now let's move on to diabetes. And so many drugs, so many drug classes are available. Have any changes taken place in the past in this SOC as compared to the previous years?
So the change that has come about, I would say, is only a part of the continuum that has changed in the last maybe 3-4 years. We have greatly changed our outlook in the way we are looking at the treatment of type 2 diabetes. So now we have this very important change that has been mentioned, that first line therapy. All this while it was lifestyle changes, metformin, and then you would go about it. So there was some other guideline which did talk about putting in some SGLT2 inhibitors or GLP-1 receptor agonists in the first line if so indicated. But ADA has come up with this guideline for the first time, wherein they have removed that metformin as being the only option in first line, and they've very clearly put it that first line therapy now will depend on the comorbidities, and it'll be a completely patient-centered treatment where you will look into the cost, you look into the access consideration, the management needs, and though it will generally include metformin and comprehensive lifestyle modification, it could also include other molecules if you think that this is better for the patient, in the interest of the patient. So that, I think, will help us decide. I mean, there have been patients, I think, sir, you will agree that all of us have had patients where maybe obese patients, or maybe with some of the cardiac risk factors, where you think, and diabetes has just started off. So you're wondering whether I should put this patient on metformin or should I start off with an SGLT2 inhibitor, but then generally the guidelines say metformin. So I think in those patients now it will be easier to decide on some other therapy. So say SGLT2 inhibitors or whichever you choose to go ahead with. So it'll be very completely individualized now. See, having removed any one molecule, as a first line and completely going about it individualized from the word go, definitely metformin will probably remain the first choice for most of the patients. But in a subcategory, maybe we are, the guidelines say that you can go ahead and choose something else.
Dr. Rakesh, would you like to discuss this from an Indian perspective? Let's talk about sulfonylureas, thiazolidinediones.
Yeah, so I think if you look at it from the Indian perspective, also I think now that SGLT2 inhibitors, at least one of them is of patent and is available in the sense at a more economical price. So I think there again this becomes important choice that if you have a patient who has a cardiovascular disease, pre-existing cardiovascular disease, now develops diabetes, so you don't have to necessarily start him on metformin, but you will individualize his therapy and look at SGLT2 inhibitors or even GLP-1 analogs. If they are going to be better off for him, then you would think of using them also, or you would also you could also combine them with metformin and use them. So those are important issues that are relevant to India also. But I think another important thing is that from the point of view of using SUs, and if you look at the table, it is now not clearly said that SUs, has put SUs also as a situation where you're looking at using the modern SUs, which cause less of hypoglycemia. So they are also finding a very important place in the algorithm, as you can see here. And the DPP4 inhibitors are particularly highlighted for their sort of being weight neutral and also causing less of hypoglycemia. So I think those are important aspects that have been highlighted in this table, and I think this has actually broken that earlier thought process that metformin has to be always the first choice. It is now clearly shown that you have to be looking at the patient's requirements, and we need to look at the background of the needs of the patient and then decide which should be the first line therapy. So I think that has been happening in the last 3-4 years in all the other major guidelines, and ADA has also rightfully made this change.
From an Indian perspective, actually, when we see our patients, many of them are obese or maladaptive anabolic. Many of them are overweight. Some are normal weight as well, but many are underweight as well. When we talk with our American colleagues, they don't see underweight patients. So they always speak of weight reduction, weight loss, but we should speak of weight optimization. If you have somebody who is lean and thin, perhaps malnourished with macro or micronutrient malnutrition, it's our work to build up the patient. Do remember that metformin is a calorie restriction mimetic. If your patient is already restricted in calories, either the patient is not eating enough, is on a VLCD or LCD, or maybe has decided to go on a keto diet. If your patient is not absorbing enough, not assimilating enough for whatever reason, then a drug like metformin and SGLT2 inhibitor will actually be counterproductive. It will actually harm the metabolism of your patient. And then you would be better off giving an anabolic drug, which can be pioglitazone, which can be sulfonylurea, and which might be, in the vast majority, it might be insulin. Dr. Rakesh, if you could continue with this, how often in your OPD, let's talk about yesterday maybe, for the new patients who came to you, did everybody follow a stepwise approach? You start with single drug like metformin, or in some, did you start with a triple drug as well? In others, did you discontinue suddenly? So what kind of rules and regulations were followed?
Yeah, so I think this is also another important change in this guideline, or probably from the last year, ADA has been shifting towards advocating the use of a dual combination when you start off with, and when you're seeing HbA1c which is more than 1.5% of the target that you're looking at. If you're looking at targeting HbA1c of 7%, then you have somebody who has got 8.59%. You can't expect him to be under control just with metformin, and many times we start with a combination of two drugs, and that is a common practice that we do in our OPD, because we don't typically expect the person many times may not come back at the time that you want him to come back, and then you see him after a year or so, and you find that his HbA1c is 10% at that time, and he has lost considerable weight, or he has developed some complications. So then you feel you regret that not having started with the dual therapy if you have not done so, and that is often a point that we notice in our OPD. So we over the years, what we have started doing is that we start using a dual therapy rather than just going by starting with a single drug, and that's what is the recommendation that is changed in this guideline.
There is something known as good clinical sense. So if your instinct tells you something, please follow it. And trust yourself, trust your patient as well. There's another issue, Dr. Arundhati, if you come to you, and that is about injectable therapy. Now, in many places, you will see discourse that the choice of first injection is GLP-1 RA. So is that true for every patient? Or let's just focus on injectable therapy. Can you classify your patients, those who need injectable therapy, into two groups? What is the phenotype which will need insulin alone? A phenotype which will need GLP-1 RA alone? And is there a phenotype where we can give both? And what does the ADA say?
Certainly, sir. I would also agree with you, so that when we are talking about an injectable therapy, it necessarily need not be a GLP-1 receptor agonist. There are a lot of patients in our practice whom we say where insulin is the choice. I mean, as you just said, this could be a catabolic patient, a lean patient who has got some complications, who's been a diabetic for a considerable amount of time, and there I would want the patient to build up. And when they refuse insulin, the first thing I tell them is you're going to gain weight. You're going to, look as handsome as you were looking 5 years back. So that helps them understand what is it that I'm talking about. I'm just not talking about blood sugar control. Even, I would say, even quite early in therapy, sometimes when these patients come to you, maybe early, but they've got very high blood sugar levels and they're really lean, they've lost weight, and they become cachectic. We see those patients quite often in our practice. There, obviously, we would think of the first injectable that we would think of is insulin and nothing but insulin. As again, there's the opposite end of the spectrum. These patients who are obese, who've got a cardiovascular issue, who's got the cardiovascular risk factors, and they are diabetic. So GLP-1 receptor agonists are also good molecules when it comes to HbA1c reduction. They have shown considerable evidence of around 1 to 1.5% reduction, which is good. I mean, not as great as insulin, not like, anything, not that anything can be achieved as you could do with insulin, but then GLP-1 receptor agonists are also good molecule, but they're for patients, I would say, just at the other end of the spectrum, maybe. And the middle part of the spectrum is where you could probably combine both if you want to. So this is like a good combination, because insulin is going to, help the patients put on weight, and there would be that category where you do not want that weight put on, but you would want the insulin. So a GLP-1 receptor agonist would not only give you the cardiovascular benefits, it would also give you the weight loss. So together, I think insulin and GLP-1 receptor agonist could be indicated in a large, part of our patient spectrum. But then again, as you said, sir, individualization. Not GLP-1 receptor agonists, even if affordable. I mean, affordability is a problem in our setup. So even if it was affordable for everybody, I mean, it was, everybody could afford it, then also it would not be for everybody. So definitely subcategories to decide which injectable to be put in first. And continuation of metformin after the patient has been initiated on insulin, I think continue with metformin. We generally, if you're taking away one molecule, it would generally be the sulfonylurea, which has been probably put. So you would want to decrease the sulfonylurea if you're putting on the patient on insulin. But metformin is something that we generally do not stop when we are putting the patient on insulin, unless there are very strong indications, unless you're, removing the metformin because of some GI side effect or something else. Excepting for that scenario, we generally tend to keep metformin, because otherwise the requirement for insulin is going to be huge. And then the patient will come back to you telling you that, you put me on insulin saying that my sugar levels will be controlled. Now the levels have gone even higher. So this is generally that we generally do in practice, and that has been put forward by ADA in the guideline this time.
Thanks for that. So these ADA standards of care are actually reflective of what we are doing in practice. And like Dr. Arundhati said, they keep on reinforcing the fact that we need to practice evidence-based sensible, good sense-based practice. When we talk of diabetes management, of course, we talk of prevention, we talk of glycemic control, but the main aim is CV risk reduction. So, Dr. Rakesh, any comments on that? What does the ADA say? And is there any change?
So I think very important this thing is that they have come out with this sort of cartoon which clearly shows the importance not only of the measures that we are taking, I mean the medications, but also the lifestyle changes which is there on the which forms the foundation, the lifestyle modifications, the diabetes education, and then the glycemic management. Not only the glycemic management, lipid management, blood pressure management, and also the other issues that they have highlighted in this clearly in this cartoon, which shows that it has to be a comprehensive approach, not just looking at using a particular molecule or using a particular drug for treatment of diabetes, but a comprehensive management. So I think that's the important message that is coming out, and now they are also, I mean, and also finally we are speaking about the agents which have a proven cardiovascular benefit, which we now have over the last few years. We have the SGLT2 inhibitors and the GLP-1 analogs, which have a special place. But while we are using them, we should not forget about a good lipid management, good blood pressure management, and also the lifestyle changes that have to be advised to the patients. So I think that's an important message that is given. And then they have also spoken about stratification of patients based on their cardiovascular risk, and deciding about the use of either the SGLT2 inhibitors or the GLP-1 RAs as based on the patient's individual requirement. And then you could also speak about, I mean, they've also spoken about the combination of these two molecules, which was also shown to have a good benefit. So combination of this two proven classes of drugs which have shown to have proven cardiovascular benefit is also an important aspect that has been discussed in this
guide. Let us take Dr. Arundhati's opinion. Dr. Arundhati, looking at this picture, I am reminded of something that was taught to me by Professor B.K. Sahay from Hyderabad. Sir has taught me that in your OPD, you keep on focusing on glucose control, which is actually quite difficult to catch. It is almost as difficult as getting Ilish fish in the out of season. While you can get equally good risk reduction if you focus on blood pressure, if you focus on lipids, which are much easier numbers to take control of. So what I've learned from Professor Sahay is that 4 of these pillars are equally strong: glucose, blood pressure, lipids, and weight. We might want to add a 5th one, like antiplatelet drugs. So what is your opinion about this quadruple of Sahay, or this quinary concept, Dr. Arundhati?
Sir, I think yes, certainly. I mean, when we are seeing our patients, we cannot keep ourselves restricted to just looking at the HbA1c. We do also need to focus on the management of hypertension, which at times I think we might become a little lax, because as you just said, we tend to be a little more concerned about the HbA1c. It's not that we are not looking at the blood pressure, but maybe at times maybe that 140/90, or okay, you just allow it, and then maybe the patient is not monitoring. You're telling the patient to monitor, his blood sugar levels at home, but a lot of times you're forgetting to tell them to monitor the blood pressure also at home. And by the time they come back after 6 months, or maybe they're coming back after a year, then you see that a lot of time his blood pressure level has gone really high, and probably it has been high throughout the year and was never monitored. So equal emphasis is something. We are treating the hypertension, we are treating the dyslipidemia, we are also putting the patient on drugs which will offer benefit in terms of kidney disease, or in terms of the cardiovascular aspect of it. But probably what the 4 pillars being equally strong, standing equally strong, they tell us that the focus, the importance that has to be given to each has to be balanced out. And though we are doing it, but probably we're not balancing it out as well. So that is what we need to do. And I think all of us have been doing it, but yes, it helps to understand that You cannot choose one over the other because you are treating the patient, you're not treating diabetes. So as a whole, we would need to focus on all of it, and this is a good figure, I would say. We need to keep in our minds in our practice.
And again, I have been guilty of this, of focusing more on glucose. And if the patient has a cholesterol of 201 or 209, or maybe an LDL of 120, I tend to brush it under the carpet. And the reason has always been that if I begin talking about maybe a statin, or if the BP is 140 by 90 and I begin talking about a blood pressure lowering therapy, then that is another few minutes of discussion. And the patient has a right to that discussion. So again, I'll be more careful now. And the advantage of doing this is that finally I'm going to save time and I'm going to have a happier OPD. If I focus only on glucose control, then 50% of the time, my patient is going to come back uncontrolled. So that means I am setting myself up for failure. But the moment I add cholesterol or LDL and I add a systolic or diastolic blood pressure to my targets, then now my hit rate is going to increase. I know it is going to jump to 90-95% because I have those weapons in my kitty. So I think that is something we should do. And this Sahay's Pentagon is something that I think we need to highlight across the country. And we've not done that so far. That is another mistake, an error of omission, and we'll correct that now in the years to come. Thank you. Dr. Rakesh, would you like to take this? What about children, adolescents, pediatric diabetes? If you could focus on children.
Yeah, I think some of the important things that have been done is that it has been highlighted that the fact that diabetes is often seen in childhood also, based on, and the fact that these children who develop typically type 2 diabetes are not protected from the complications. They are at very high risk of complications. So it's important to stratify and screen them for complications. That's one important aspect that has been highlighted. And in the previous section also, Dr. Arundhati was highlighting the fact that whenever you have a patient who is not typically fitting into type 1 or type 2 diabetes, then you need to screen them, do the genetic test to look for MODY and for these single gene defects which could be contributing to the development of diabetes. So I think those are two important things, and the fact that we need to be more proactive while managing our young patients with diabetes is also an important change that has been brought about in this guideline.
If we can go on with this discussion, Dr. Arundhati, how often do you see type 2 diabetes in children? And how often do you see type 1 diabetes in adults?
I think over the years, the number of type 2 diabetes in children that we've been seeing, all of us have been seeing, has actually increased. I do remember a lot of times when you would have diabetic patients, obese diabetic patients, and then they come in with their children and you ask them to get them tested. Most of the times they would refuse to get a blood sugar testing done. And I do remember a particular case who came back to me with a blood sugar level of 400 plus, having refused to get the blood sugar level tested earlier on when I had asked them around 6 months or a year back. So, but I think with more of awareness, people are getting aware and they're getting tested, because we need to remember that type 2 diabetes might remain asymptomatic for a very long time in these children also. And by the time they present, it could be quite some time before that they've had diabetes. So I think sir, we would need to raise the awareness level, probably take it up to the schools and more, because I'm sure though we are seeing quite a number these days, we are missing out on a large number as well. So because these children are not getting tested, they are not getting tested no matter what their risk factors are, they're not getting tested. So probably it is time for us now to act and increase the awareness levels about these children, these type 2 diabetic children. Type 1 diabetes in adults also, sir, I would say that I am seeing quite a few. And then there is this initial denial that, this is not type 1 diabetes, and I'll try with medicines. And then eventually they end up in a very catabolic condition, some of them in ketoacidosis, some of them with very high blood sugar levels. So we are seeing them also. Percentage would be difficult to say, but maybe around, maybe I don't know, maybe 5% or something, 2 to 3% maybe,
yeah,
of our practice patients, adults, are type 1 diabetes.
There is another phenotype that we see here in northern India, and maybe there is no specific term for this, but this is women who are diagnosed as having gestational diabetes. They fit all the criteria for gestational diabetes. They do not fit the criteria for pre-existing diabetes. But when you look at the phenotype, that is a classic autoimmune type 1 diabetes phenotype. And the only way you are able to confirm the diagnosis is if you do the antibodies at that time. But that unnecessarily adds to cost and to stress during the gestation period. After delivery, what happens is you're not able to wean them off insulin. And then that creates a lot of hue and cry and a lot of ruckus in the OPD. The patients blaming us, the parents-in-law blaming the parents of the girl who has diabetes. So that's another issue. And this is most probably LADA, an autoimmune diabetes, which was doing fairly well. But then when that glucogenic stress of pregnancy got added to whatever was going on earlier, then that beta cells decompensated. So this is something that we are seeing more frequently, and we had not seen it earlier. At least I had not experienced this about 10 years ago in my OPD. But now it comes more and more frequently. And earlier, I used to think that this particular phenotype was limited to one or two ethnic groups in Northwest India. But now I see it across all languages, across all social classes. Dr. Rakesh, you have been at the forefront, and especially Hyderabad has been at the forefront of focusing on diabetes retinopathy awareness, diabetes retinopathy screening. So what does the ADA tell us about that?
Yeah, so ADA is actually emphasizing the need for screening for retinopathy at every visit. I mean, at every year for people with type 2 diabetes, and using simple fundus photography to handheld fundus photography to screen for that, and appropriately take measures depending on the results of the screening. And also they have highlighted the need for doing the importance of doing CGM studies, whether you look at the real-time CGM or the intermittently scanned CGM. Both of them have a very important place in the management to improve the care of people with diabetes. Particularly here they have highlighted for youth with type 2 diabetes, and where they have highlighted the importance of this CGM, which will certainly help in improving their glycemic control. And also on they have also highlighted on the need for regular BP monitoring in the younger onset of type 2 diabetic patients. Even though, I mean, this is one group where often we forget to check the BP regularly. This is one group which should be, where we should focus on checking we should not forget to check the BP at every visit. So this is, I think, another important observation in this guideline, which is clearly made out.
What the ADA reminds us is, Dr. Arundhati, your comments on this. We spend so much time talking about CGMS and about time in range, about glycemic variability, because we feel we are diabetes care professionals. And do we spend the same energy talking about ambulatory blood pressure monitoring and about variability in BP? So what is the current status in India, and what should be the way forward?
Certainly, sir, we do not. I think I'm speaking for most of us when I'm saying that we have become used to talking about CGM now. We've been talking about SMBG earlier on. Now we talk more about CGM. But regarding blood pressure, excepting for when patients have very high blood pressure levels, or maybe they talk of fluctuations, is when we think of ambulatory blood pressure monitoring. It is not something that we think regularly, but what has come forward in the form of studies is that ambulatory BP monitoring at times brings out high blood pressure or blood pressure variations in a lot of people in whom we miss it in the OPD, or vice versa. It could be a white coat hypertension, which is otherwise normalized. So ambulatory blood pressure monitoring, I'm sure, is going to come up in a big way, and it is going to be probably years from now. People would say that there was a time when this was never done. So probably we are reaching towards that pathway where ambulatory blood pressure monitoring should be a part of looking at people who, particularly young people who have high blood pressure, and for whom we are treating for high blood pressure. So yes, I think, sir, we are not doing it as yet, but with the guidelines telling us now, and we are talking more about it now, so gradually I think it's going to become a part of our practice.
Yeah, so the ADA says you do ambulatory BP monitoring in people with early onset high blood pressure, in adolescents, in younger adults. But I guess also in people where we find it difficult to manage BP, where the symptoms are not concordant with the BP readings. Maybe the patient is in denial, or maybe we worry that we are causing side effects with our drugs. So patient comes and says that I have symptoms suggestive of hypotension, but our reports, our BP reading says hypertension, or maybe the home readings are different from the office readings. So wherever there's a confusion, I think we should do this, and we need to, all of us need to sort of become more proactive in this regard as well. We have many other topics listed, but it's already 1 hour now. Dr. Rakesh, would you like to take this? Uh, Obesity, what does the FDA say?
Yeah, so I think this is a important area because there are many medications which are available in the approved by FDA, but which are not available in our country. So that is one area which where we differ in terms of the management. But I think the most important factor here is the importance of dietary changes, and we have many different diets being advocated in our country, and many patients are using different diets for weight reduction. And but I think the important message given here is, I mean, a comprehensive list of all the medications that have been approved by the ADA, by the FDA. FDA approved medications for the treatment of obesity are listed out by the ADA guideline, in this ADA guideline. And I think those are listed out here. And of the ones which are listed out, probably I think the GLP-1 analogs, the higher doses of the GLP-1 analogs which are mentioned are relevant to our population, whereas we don't have the other ones available here in the form that is approved there. So I think the most important thing again is about a comprehensive management, lifestyle management, and identification of those who are those who are suitable for going for even for bariatric surgeries. I mean, those individuals, identifying those individuals who would benefit from bariatric surgery, also recommending them those measures, because that is also something which is going to bring about a significant improvement in the not only the glycemic control but also reduction in the cardiovascular risk.
Dr. Arundhati, relevance for India, any developments that we can expect in the coming years?
So I think the availability of these two molecules has been mentioned. I mean, once they become available in our country, because the others are not, apart from, I mean, generally speaking, when we're treating obesity, apart from orlistat, there is nothing much that we have in our hands. Liraglutide 3 milligram or semaglutide, maybe once weekly, once they start in India, when they start to be used in India, probably that's going to help us. But I think one important area that they've said is that I'm a little, I wish this was answered, because we've been using dietary supplements, and obviously they have looked at a much bigger evidence, and they've found reason to say that they do not see dietary supplements as effective for weight loss. We have been using dietary supplements, low calorie diets, and others, as diet substitutes, as meal substitutes for weight loss. So now, if ADA says that there is a lack of clear evidence, I think we would need to make some changes in some of our patients in whom we have been using those. But yes, once the other two molecules become available, the cost might be an issue. But yes, for those in whom cost is not an issue, probably we'll be able to offer them the benefit of obesity management.
So 360-degree discussion today about what the standards of care 2022 from the ADA have brought to us. We've talked about everything, right from our approach to diabetes care, using community health workers, using a focus on diabetes literacy, numeracy, oracy, to the need for good glucose control, along with early and timely screening and follow-up of our patients. We've talked about managing pre-diabetes with metformin. We've talked of how to choose the right glucose-lowering therapy. And then Dr. Arundhati and Dr. Sahay have Added to that, the fact that we need to focus on blood pressure, on lipids, and on overweight, and also CV risk reduction. And I'm sure if we are able to do all this, we will be able to improve the diabetes care of our country. But before we conclude, perhaps Dr. Rakesh and Dr. Arundhati, if we can go on with Dr. Arundhati first, one single message that you would like to share with everybody. What is the single thing that you've learned from ADA Standards of Care 2022?
One single word would be, sir, what we've been redefining for the last few years. I would say we have redefined the way we are looking at our patients, and we have, these guidelines have helped us actually individualize therapy. I think, sir, my practice has changed a lot in the last 5 years. Now when I'm looking at the patient, I'm thinking of other benefits, I'm thinking of a lot of things. Earlier on, I was just concentrating on maybe just the HbA1c, the fasting, the PP. Now we have so many technologies available for us, we have newer options of treatment, and we have a new way of looking at things. We have, CGMS, we've got ambulatory BP monitoring, we have technology, we have apps, we have these guidelines. So all in all, I think we are in an era where there's been a lot of change to our benefit and to the benefit of the patients.
If I may just add to that, I mean, I think 2 or 3 things that Dr. Arundhati has already said, that I think the important things that are striking in this guideline is about the first line therapy for managing diabetes, the approach towards emphasis on taking care of pre-diabetes, and also having a holistic approach in terms of managing just not the hyperglycemia but also the blood pressure, blood pressure, lipids, and all the other risk factors. And the other important thing is incorporating the use of technology for the benefit of patient.
अगर आंखें सुंदर हो तो सब कुछ सुंदर दिखाई देता है, and that is what we learned from both our panelists today. If your eyes are beautiful, you see the world as being beautiful, and they see diabetes care as being a very beautiful process, a process in which you are actually able to bring out beauty, health in your patients, and also in the community. Use whatever is available, whatever technology is available. Be mindful of economy, of cost constraints, and keep the patient, the person living with diabetes, at the center of all your thinking. If you're able to do that, then automatically your actions will be geared towards that individual, and you will be able to get the best possible outcomes. It's been great having you all with us today. I understand it is a Sunday evening and there are many, many more things to be done. And then Dr. Rakesh talked about being holistic. Dr. Arundhati is an expert in juggling so many things, a work-life balance. So we've had a lot of work today, a lot of academics. For the rest of the evening is yours. But Dr. Apurva, back to you before we conclude.
Thank you.
Thank you, sir. Thank you, Dr. Arundhati ma'am. Thank you, Dr. Rakesh Sahay sir, for being with us today and covering a whole exhaustive ADA guidelines and giving us a new direction in how to go about managing diabetes in a more effective and guideline-directed way. We have also touched upon what we have been doing, what we have been ignoring. So it was a very insightful and very interactive session. Thank you all of you for taking out time and being with us on a Sunday evening. With that, I formally announce the end of today's webinar. Thank you and have a very great evening ahead.
Thank you.
Thank you.